A case of posterior subcapsular and capsular cataract. I'm doing a rhexis under the viscoelastic through the pinpoint tunnel floor entry method. I could not complete the rhexis at the fag end because of the peripheral runoff. I'm retrieving it using the Utrata. I do a hydrodissection to separate the capsule from the subcapsular opacity as a routine. Very gentle pressure, the chamber is kept open. Turning the cannula tip backwards towards the equator, I could have a fluid wave separating the capsular opacity from the subcapsular opacity. There is no increase in the intralenticular pressure, which will force the opening of the posterior capsule. The nucleus epinuclear mass is not separated from each other, so it's easy to remove them together in one go. Not to stretch the tunnel, I have divided the nucleus into two pieces, and each piece is being taken out of the anterior chamber under continuous viscoprotection. The cannula is continuously injecting viscoelastic in front of the nucleus, while the wire vector guides the nucleus to come out. Capsule is not pressurized at all during the hydrodissection. You can see the aspiration of the cortex is very easy from the capsule because of the hydrodissection. There are opacities in the posterior capsule which I'll try to polish them, but in this case it was not possible to polish them completely because of the fibrotic nature of the capsule. So there is a single tunnel entry, and you need the assistance of subincisional Simcoe cannula, the right and left, to remove and polish the anterocapsular back. That is opacity, you can easily see. I'm trying to remove it with the polisher, but it's very stubborn, and I decide to leave it behind. I have an option of doing a posterior axis, which I'm not doing in this particular patient. It's very stubborn ring-like opacity with very thin center. If you pressurize the anterior chamber, that central area, which is the one which will give way, creating a posterior capsular dehiscence, which occurs intraoperatively. Lens is placed inside the capsular bag. This patient had wonderful vision postoperatively. The capsular opacity, fibrotic in nature, did not come in the way of vision. Entire viscoelastic is removed. Lens is centered, and the tenon conjunctival flap is closed with fibrin glue. That's the end of surgery. There is no need to band-aid the eye. Eye medications can start immediately, and the patient will have instantaneous visual gratification. Thank you.